Hi, Mr. Taylor. I want to talk to you about your current diagnosis as well as next steps in your treatment plan. Your rectal cancer did come back as a stage T3 into M0. What that means is that the cancer has spread into the muscular layer of the rectum as well as some surrounding tissue and fat. The N2 means that it has spread to 4 more surrounding lymph nodes, and M0 means that there's been no evidence of metastatic spread of your cancer to other organs in the body, which is good. Treatment for rectal cancer is extremely curative, has really good outcomes even at higher stages. What you've already undergone is called neoadjuvant chemo and radiation, and the purpose of that was to shrink that tumor as much as possible before undergoing surgery. According to your recent CT scan, that was extremely successful, which gives us hope for this next step we're going to talk about today, which is called a restorative proctectomy, in which the surgeon will go in and completely remove your rectum and create a coloanal anastomosis, which means a fancy word for a new connection in which you'll pull your colon from your colostomy back into your abdomen and connect it to your anus, kind of filling that gap of what was removed. And then he'll create a temporary ileostomy, connecting your small bowel this time to your stoma externally versus your large intestine, which has been there. And the purpose of that is just to give that new anastomosis or connection time to properly heal before allowing stool to pass through it. And then 6 to 8 weeks later, he'll go and reverse that to ensure your bowels are all confluent again and running properly. The risks that are associated with this surgery is always going to be bleeding, infection, and anastomotic leakage or leakage from that new connection. Rates of this are extremely low. If they do occur, it's going to be in the first few hours to days after your surgery, which is why we keep you in the hospital 1 to 3 days post-op to monitor your labs and ensure there's no complications. Risk of not undergoing this surgery would be metastatic spread of your cancer that's currently contained, potentially to a state where it's non-curative anymore and we no longer can treat you. And then also complications like abscesses, fistulas, things that you don't necessarily want to develop. That's the cornerstone of treatment. There's really no alternatives other than surgery for a curative state of this cancer, so we do highly recommend it. I can assure you there's a high success rate. You'll be on tight surveillance post-surgery to ensure that there's no reoccurrence of this cancer, and if it is, obviously we'd catch it really early with repeat colonoscopy a year later from surgery, but we'd see you in the office every 4 months for the first 2 years, and then every 6 months for 3 more years after that, repeat CT scans every 6 months, and then keep up to date with yearly colonoscopies. That's our plan. I hope some of that made some sense to you, and then we look forward to taking care of you soon.